Okay, thank you all, welcome. Thank you all very much for choosing this workshop. Hopefully by the end of today we're going to understand a bit more about the shoulder, the anatomy, the physiology, the pathophysiology. I'm going to show you a technique that I've been working with for about 15 years that helps to center the glenohumeral joint, thus improving strength and power and reducing shoulder injuries. We're going to talk about that. So the first thing we're going to say is this, is that actually you guys are at the front line of shoulder injury prevention. It's beholden upon all of us, not the doctors, to actually understand how the shoulder works, to understand the mechanisms of shoulders, and to talk about how we can help people during their training. So understanding the types of injuries will help us prevent injury, and understanding trigger points, because that's how I've been working for many years, and how they relate to form and function will help us deepen the understanding of the musculoskeletal mechanics. And correcting and balancing shoulder mechanics, we call it natural power enhancement, NPE. It enhances shoulder postures, more efficiency, and actually increases strength and power. We've got some data to share with you from some clinical studies. So about me, briefly. Okay, so I'm an osteopath. Graduated a number of years ago now. I did a postgrad at Exeter, and I've been using trigger points for 23 years. I've written a few books. There's one here for you to look at, the concise book of trigger points. And over the years, I've developed a speciality now in shoulder pain, shoulder pathologies, and really, really excited to share it. So I'm trying to do an evidence-based lecture. It's based on more than 2,000 shoulders that I've treated personally. They're also based on the work of Dr. Jeremy Lewis. I'm sure many of you have heard of him, or he is great. And what's clear is that you guys have a big role to play in shoulder injury prevention and shoulder injury treatment, but also trigger points have a really important role. And if we understand them better, I think it's going to improve everything. So the other important thing, of course, is to view shoulder pain in the context of the whole body. We can't separate it. You'll come to see later with some of the interesting studies by Kibler that if someone has a foot problem, a big toe problem, and their weight transfer is different, it's going to have a different mechanical effect on the shoulder. So we've got to look at the shoulder in context of the whole body, but of course we need to understand how it works. So let's start with a few facts. First of all, shoulder pain is very, very common. It's the second to third most common complaint seen in the general population. And 1 in 3 people will have shoulder pain at some point in their life, and the incidence increases with age. It's really important, really important. So the other thing is that shoulder pain is really painful. It really affects people's quality of life. It's got a high morbidity rate. 50% resolves within 6 months. But actually 40 to 54% of people report ongoing symptoms for 1 to 3 years after a shoulder incident. So understanding what they are, understanding how we can correct them, and understanding how we can help people move forward reduces all of these. And interestingly, a study that was done 2009, hello, welcome, shoulder injuries are the 5th most common injury amongst high school athletes. Does anyone know what the most common injury in sports is in America? What the most common sport is? Cheerleading. So I'd share that. Now, often shoulders come to us with the wrong diagnosis. They're often diagnosed as subacromial impingement syndrome, frozen shoulder. A lot of things are called a frozen shoulder that really aren't a frozen shoulder. Rotator cuff, bursitis, and often actually these are incorrect. So again, importantly, we have to understand what is the actual diagnosis that we're working with, because that will affect the way we treat people, the way we manage them. Surgery, hugely overused procedure for shoulders. 95% of shoulders can be fixed by hands-on techniques, 95%. Okay. There's no evidence, in fact, to support subacromial decompression. I've got the references if any of you need these. And this, the overuse of surgery is a huge problem, with billions and billions of pounds wasted every year. So this was an interesting validated study. This was the measurement and valuation of health status using the EQ5D, which was a European directive, and it looked at what the impact of sort of different diseases, different complications are on people's lives in Europe. And in fact, it turns out that musculoskeletal pain is rated as highly as heart disease, chronic liver failure, diabetes. People rate musculoskeletal pain very, very highly in terms of their quality of life. So let's see why. So why do people get shoulder problems? Okay. First of all, we live longer. The shoulder was designed for about 40 years, and that was it. In fact, most things were designed for about 40 years. So we're living longer, and the soft tissues themselves develop incompetence. They develop incompetence. Sitting, a lack of metabolic activity, not so important for you guys, but in the general population, there's a lack of metabolic activity, as we were just hearing before. And then we've got this new condition called underloading. So you're going to hear more about that over the years, tendon underloading, where we lay down the tendon sort of fibers, the type 1 collagen fibers, sort of during the puberty, as we were hearing before. And if we underload a tendon, actually they don't develop properly, and they become weak and incompetent. And the other one, really important, is occupational. So anything above the head, any hand postures above the head are going to compromise the shoulder mechanics. And in sports, anything above the 90 degrees, also sudden loading. And we're going to talk about tendons later, how they don't really like change. They're fine. And the other thing is other injuries. So let's say, as before we said, if you have an injury in an ankle or a foot or a knee, you're going to compensate the way you use with the shoulder, and you're going to possibly lead to more shoulder pathologies. We have to see it in context. So, lifestyle factors. Interestingly, there's been studies to show that tendons, especially shoulder tendons, do not repair in the presence of nicotine. So anyone that has a tendon operation and goes and smokes, they might as well have not had the shoulder repair. So this is kind of some of the reasons why. Let's go back a few million years, and we look at the human shoulder. And I want you to look at the scapular changes. We're going to look at the spine of the scapula here, and we're going to look at the direction. So in the gorilla, which is the more ancient of our cousins, we can see the spine of the scapula is angled vertically, and the gorillas are great at hanging and swinging on trees. In fact, gorillas don't get many shoulder injuries at all. This is studies that have been done, especially compared to the humans. Chimpanzees, somewhere in between, we can see the spine is starting to change directions. But look what happens in the human. As we become upright, you can see that the glenoid fossa has moved sort of inferiorly. And this leads to changes in the glenohumeral alignment, and it leads to mechanical compromise of the subacromial space. And the subacromial space is really where we're looking for a lot of shoulder pathologies. A lot of stuff that you're going to see is in the subacromial space. The human shoulder is excellent, really excellent, up to 90 degrees. But above 90 degrees, it's compromised. And that's really where the danger zone is for us. So let's look at some studies. So this was a study done in 2004. It looked at different occupations, and we can see that the mechanics, house painters, machinists working the same job for more than 10 years. In other words, people that are working above their 90 degrees. The MRI showed really interesting, distinct degenerative changes in the supraspinatus tendon. Again, another study done in 2000 looking at swimmers showed that by employing a different stroke at the end of range of swimming, you can reduce shoulder pathologies. And again, you guys know this stuff better than me, I'm sure, but forgive me. But in terms of energy transfer, it's very interesting. When we think of someone playing tennis, we think it's a very shoulder-intensive sport. But this study, again, I think it was done by Kibler, shows that during a tennis serve, the shoulder only takes 21%. In fact, the rest of it comes from the rest of the body. The leg and trunk, 54%. So you can imagine someone that's got a hip, leg, knee problem will start to develop shoulder problems and this is actually borne out by evidence. This was a study done in 1995 that showed in pitchers, I know it's American, a 24% energy decrease from the hip requires 34% energy increase at the shoulder to deliver the same amount of force. So important. The hip and trunk extension facilitates scapular retraction, and hip and trunk flexion facilitate protraction. Okay? And at this point, we're going to talk about the thoracic spine, because there's interesting studies on the thoracic spine about kyphosis. There's a lot of stuff now about posture, and is posture related to injury? What is related to injury is mobility of the thoracic spine. If someone's got a stiff, immobile thoracic spine, they're more likely to get shoulder problems. So again, when we're looking at the shoulder, we're looking at the whole body. We're looking at the feet, the ankles, the hips, the knees, and we're looking at the thoracic spine. Really important. Sometimes just treating that thoracic spine can improve the shoulder function and decrease shoulder pain. So don't think that young people can't have shoulder pathologies, severe shoulder pathologies. This was a study that was done on pitchers. Now, it's very, very interesting study, because this was asymptomatic athletes. In other words, they had no symptoms at all. Took them in for an MRI. Average age was 22, okay? So you're talking about a young population. Average years in competition, 14. This was for pitchers and for tennis put together. And the findings was that 40% had a partial or a full thickness tear of the rotator cuff. 40%, this is asymptomatic people, okay? People that are going to walk into your clinics. 90% had joint effusions, 48% had subacromial effusion, and at 5-year follow-up, all were asymptomatic and all continued competitively. So what we're starting to see now is that actually the shoulder is designed for 40 years. When we overuse it, when we use it above 90 degrees, we start to get shoulder pathology. The question is, actually, if you MRI anyone over 40, they're going to have shoulder pathology. The question is, what switches on asymptomatic to symptomatic? And I think that's really where the secret is. Again, looking at sports, this was a good study done in 2009. Showed that shoulder injuries were more likely to occur during competition than practice. Shoulder injury rates were the highest in football, wrestling, and baseball. I think football means American football, sorry. Common shoulder injury diagnosis included strains and sprains, contusions, fractures. And really importantly is that trigger points will develop in injured muscles. Trigger points reduce the efficiency of a muscle. We're going to talk about it later, but trigger points are ubiquitous in terms of shoulder problems. So what are the three big problems? Well, the first one is, we call it now SPS. This is the new name you should all get used to, which is called subacromial pain syndrome. That used to be called impingement, a whole range of sort of subacromial space pathologies, bursitis, but we call it now SPS. So we're going to look at subacromial pain syndrome, rotator cuff tendinopathy, which I know you probably know more about, and the frozen shoulder. Now, I'm going to bring in the frozen shoulder mainly because it's my passion, but it's not so relevant for you guys because you probably won't see them yet in the athletes. However, understanding the biomechanics and the kind of pathophysiology behind the frozen shoulder unlocks a lot of other shoulder complexes that we're going to look at together. So the subacromial space, well, it's a complicated region. As we said, mechanically, there's not much space there anyways because of the evolutionary changes, and there's lots of stuff going on in that subacromial space. We've got between 6 and 12 bursae. We've got, now I'm not sure how many of you know what a Bursar looks like. A Bursar pretty much is like one of these. It's a thin, lubricated sheath that stops things rubbing on one another and very easily inflamed. And we're going to look at the Bursar in more detail now because it's absolutely crucial for some of these subacromial space syndromes. Of course, when it becomes inflamed, it causes friction problems. The subacromial space consists of the coracoacromial ligament, the humerus, the rotator cuff tendons, the long head of D of biceps brachii, the subacromial bursa we talked about, and the shoulder joint capsule. So there's a lot stuffed in there. But the bursars are interesting because only recently we're finding out more about how a bursar works and what it's like. When we take some of the, if we take an assay of what's inside a bursar, we can see that it's very active structure. It's very active. It's got a lot of cytokines in it. It's got a lot of neuropeptides, and all of these are potential mediators of inflammation. It turns out that the bursar has got more small sensory fibers than almost any other structure in the shoulder. It's packed with mechanoreceptors, the Ruffini endings, the free nerve endings, Pacinian corpuscles. And actually, when we look at a bursa, and the subacromial bursa is huge. I mean, just look how big that is compared to other structures, all the way down that under the deltoid muscle, packed with proprioceptors, which means that whenever if there's any impact or any trauma to the shoulder, if there's any pathology, as soon as we get above 90 degrees, we're going to start impinging on that bursa. That's one of the reasons why clinical sort of these, I don't know if you learn shoulder testing maneuvers. Do you ever do that, how to differentially diagnose between acromioclavicular? So a lot of these tests aren't actually that valid, that can't be validated, because anything above 90 degrees, you're going to hit that bursa. And there's more and more studies to show how important the bursa is. Obviously, highly relevant to you guys.
Can I ask a question?
Please, yeah.
You spoke about bursas being, and highly sensitive mechanoreceptors.
Yes.
Some GPs would, inject steroids, corticosteroids,
right.
Alleviate the symptoms.
Yes.
Regarding a GP or sort of sport doctor doing that to an athlete, how would you find out the joint position sensing?
It's very, very interesting. Steroid is not really necessary a lot of the time. Okay, we can do it without. However, what's really interesting is that an ultrasound-guided steroid injection into the bursa actually has a great effect, much more than into the joint itself. So it turns out that ultrasound-guided bursa injections can reduce symptoms, and they're much less dangerous because you're not getting in the joint space, you're not affecting any of the tendons. So that's kind of one of the reasons I'm focusing on that.
But in expansion, do you know how that would affect joint position sensing to increase injuries?
Again, if you're not injecting into the joint itself, you're going to not have any of those sorts of risks. But of course, if you put steroid into a joint, we know that it has trophic effects on tendons. More than 3 steroid injections in the same joint can destroy tendons. We try and avoid it if we can, but actually it turns out that injecting the bursa, but it's a difficult injection because you need an ultrasound to guide it. But it turns out that it's as effective as steroid into the joint and much less dangerous for athletes.